in the chat. So I'll briefly introduce Michael, who I think actually probably needs no introduction. But Michael is the social worker for the Homeless Palliative Care team at Harborview and the co-director for the Palliative Care Training Center at the University of Washington. They research and speak on the intersections of homelessness, serious illness, and psychosocial care. Michael completed an MSW and an MPH in global health at UW. They previously worked in emergency medical and psychiatric care and provided training and research support for medical social work and palliative care in Cambodia. Michael is distinguished faculty with VitalTalk and a former New York University Zelda Foster Fellow in palliative medicine. And I learned so much from Michael every time they open their mouth. And so I am very thrilled that you are willing to speak to us today.
Thank you so much, Laura, and everyone for having me here. Um, I said yes to Laura because it's Laura. And so, Laura, thank you so much for being the person to bring me here today. I have no slides for you today, and I have a lot of things to say, and some of the things are things that are new for me to talk about. So I was in the palliative care office at Harborview yesterday, and I mentioned to Laura, and I will say to you, that I've actually struggled a bit in preparing for this talk. And I've written some words to help me keep my thoughts organized as I talk about that. It's actually kind of a strange experience because this is my 10th year of practice with the Homeless Palliative Care team. And I have talked about this work for many years in many ways and for many, many, many hours. So the difficulty with this talk kind of surprised me. And what I realized in looking at that is that in the 10 years that I've been doing this work, the world is in a different place. And I feel like I'm in a different place. And what matters to me is changing. Hmm. This work has really so much meaning to me. And being in this community practice has meaning to me too, which is why I agreed to do this thing that was feeling challenging. What I'm not sure of kind of right now is what feels meaningful to say to you today. And more pointedly, I'm not sure what might have meaning to you that might influence the experience of care for the people that I care about so much. I'm not sure I know how to do that, and I'm trying to learn. But I decided that I get to decide if Laura invited me to talk, and that I get to decide what I say and how I use this space. So I'm going to share what's been on my mind and what's been on my heart and what matters to me right now. The process has been elucidating and sometimes painful, and it feels really vulnerable to share it with you, perhaps in a way, as I reflect on that, that might feel really familiar to our patients as they're asked to reflect on challenging things and what's most important to them. I promise I will talk a bit about our outreach team, and I'll try to share some of the ways that I think about the adapted frameworks for palliative care practice with people experiencing homelessness. I also hope to highlight the stories of the people who taught me to engage uh, in their wisdom and curiosity. And I'd like to invite you to think about what you hope to both give and receive from this time together. I'm going to open with some words of reflection that I wrote to try to, again, think about what is really on my heart right now. And truly, what I've been reflecting on is about how palliative care really is sacred work. The palliative care is the practice of relieving suffering so that people can live their fullest lives. And some of that work is clinical, but most of it is grounded in human connection, bearing witness to grief, honoring the stories people carry, and supporting their search for joy and meaning, even when suffering can't be fully eased. We talk about hopes and values and worries, and sometimes even miracles. And we accompany people through some of the most challenging experiences of their lives, experiences that can be deeply clarifying, even enlightening. When approached in this way, our work becomes a spiritual practice as much as a clinical practice. And at its best, it's an act of love. It's also true that we do this work in a very fractured world and within very broken systems. And for many of us, this reality feels increasingly present and painful. Violence and hatred seem to grow like a cancer, obstructing our freedoms and invading peace and threatening our survival. And just as our patients remind us of our own mortality, the world's suffering reminds us right now of a shared vulnerability, that this is our suffering, not just the suffering of others. And for some of our patients, many of my patients, this has been their reality for years and generations. The constant grinding presence of chaos, inequity, and violence. The people we will talk about today have been living in a state of unrest for a long time. They've been pushed to the margins, attacked, forcibly removed, disenfranchised, denied resources, and murdered. This is suffering that has long been metastasizing in our communities. We're now called to share it, not to be consumed by it, but to be transformed by it. When I think of pain in the context of our work, I remember that pain is something that signals to us that something is wrong. And for many people, it drives us to seek care, to examine our ails, and to search for a cure. And in that interrogation, we might discover despair, sadness, and fear. We might also access our sacred rage, an anger rooted in justice, born from the violation of core values, basic dignity, and shared humanity. Sacred rage calls us to protect what matters. Shaken from our comfort, it invites us to ask the same question that we ask our patients. Given this situation, what matters most? And it may be sparked by a boundary crossed, but our sacred rage is rooted in our capacity for love. And held with an open palm, we can carry both rage as a compass towards justice and love as the force that moves us toward healing. And I want to be very clear that accessing our capacity for love, connecting with love, is not spiritual bypassing, does not minimize harm or excuse injustice. But it does keep us tethered to the spiritual practice of healthcare, ensuring that our technical skills are guided by moral clarity and a deep regard for human worth. I don't need to say it because Bad Bunny did. He was intentional this weekend with his words. The only thing more powerful than hate is love. Connecting with this love is precisely what our patients need most right now. Especially those who have shouldered the weight of injustice far longer than we have, and especially those with the visible scars that cause us discomfort. They need us to arrive with empathy, to be grounded enough to check our biases, to invest in bridging deep chasms of trust, and to engage creatively to narrow disparities in suffering. They need us to work towards justice in the world, and they need us to show up with love at the bedside. So as we begin today, I'm going to invite you to join me in a brief metta or loving kindness meditation. It's a practice from Buddhist teaching that focuses on cultivating compassion, love, and goodwill for oneself and others. It's a practice of developing empathy and deeper connection with others while promoting inner peace and emotional healing for us. You don't have to participate. You don't need to close your eyes or find your breath or be in your body in any particular way, especially if that feels like an unsafe and uncomfortable place to be right now. All I ask is this be an invitation for reflection in this moment. But I'm going to read some words and ask you to direct your focus and reflect on the words as I say them, first thinking about yourself and hearing the mantra that may I be happy, may I be well, may I be safe, may I be peaceful. We can try then to extend that same feeling, those same wishes, to the family, friends, and the people that we love. May they be happy, may they be well, may they be safe, and may they be peaceful. If we can direct those wishes towards people we don't know well, people we've not met. May they be happy. May they be well. May they be safe. And may they be peaceful. And we might even offer those blessings to those with whom we have conflict or those who elicit suffering. May they be happy. May they be well. May they be safe. May they find peace. And finally, we might radiate these wishes universally to all creatures everywhere. May they be happy. May they be well. May they be safe. May they be peaceful. I've been crying a lot this week. Before I go further, Laura, I want to thank you for the chance to do this, to be able to be in touch with this part of myself that has been hard to access lately. I want to thank you, Laura, too, for your introduction. Again, my name is Michael Light. Laura shared a lot about me, and I want to share a bit more and contextualize that introduction a bit more as well. Beyond my name, when I show up in this space, in any space of my practice, I also reflect that I carry a lot of different identities with me. I am a white, male-presenting person, though I am queer and genderqueer. I am neurodivergent, able-bodied, above median income, a natural-born US citizen, and a monolingual English speaker. I also have a history of mental illness and homelessness, both of which I did not identify with until years later because my privileged identities obscured my experience of them. I couldn't even see myself in those identities because I couldn't imagine they could be me. And I reflect on my identities here with you today because I think it's important that we all reflect frequently on how our identities shape our experience, our worldview, our beliefs, and our access to resources. They also frame our biases and the stigmas that I and we project on others and internalize within ourselves. To quote Anais Nin, we don't see things as we are, we see them as we are. And it's important because many of us on this call have outsider status to many of the identities and experiences of our patients, especially the people that we might be talking about today. Many of us hold identities and come from social positions that also reflect the people and institutions that have caused harm to our patients, their families, and their communities for years. And presumably everyone on this call holds relational positions of power with our patients, me included. It's a reality and it's our responsibility to recognize and address it in our role as clinicians and leaders. You heard in my bio what I do, but what you didn't hear are some other things. You didn't get a chance to hear that I love to hike and be in nature. That being in any body or pool of water is my favorite thing, my absolute favorite thing. I have a list now on my phone of hot springs around the world in a Google map. I love to be in movement. I love to dance. And I think a lot about my spiritual life and practices more now than ever. Laura was right in my introduction. I work as a social worker on the Homeless Palliative Care team at Harborview here in Seattle, and I work as a co-director of the Palliative Care Training Center at the University of Washington. And I say work here, work as with intention, not that I am a social worker and a director, because those are roles that I have, but they are not who I am. It's important for me to acknowledge this, to disrupt the internalized white supremacy culture which pervades most of healthcare and academic institutions. It's white supremacy culture that values individuals over community, our roles over our relationships, and our achievements as the center of our value. In this way, white supremacy culture steals our dignity and our shared humanity. And we can plainly see the manifestations of white supremacy and abject bigotry and racist policy in the news every day. But it's sometimes harder to see how its tendrils insidiously manifest in many aspects of our daily life and the ways in which they normalized and are internalized. White supremacy culture is the reason that we live and work on stolen land and a society built upon stolen labor, specifically from indigenous people, enslaved people, primarily of African descent, immigrants, incarcerated individuals, and women. Acknowledging this exploitation and honoring the people who have been stewards to our resources and contributed to our ability to do this work today is necessary to be in right and authentic relationship and to honor our own spirit and connection to others. It's part of how we connect with love and show up with love. It's part of a foundation of anti-racist and anti-colonialist practice. I'm very, very proud of the work that I've been able to do, and I recognize that it's built on the work and wisdom of others. So thank you so much for the bio and the introduction. Today, I want to explicitly and specifically acknowledge some of the people who have most directly influenced my practice, but also the heart of how I pursue this work. I want to thank my colleague, Erica Crichton, who was my MSW Practicum Foundation teacher at Wellcome Hospice, my first full foray into hospice and palliative care work. Still a good friend. I want to thank Jamae Rivara, Taryn Lindhorst, Kira Schreiber, Whitney Butler, Kari Hilwig, Erica Moore, and Jennifer Lichty, some of my social work heroes here in Seattle who are a compass and a guide and a support system as I learn how to do this work. Ian Johnson and Abby Latimer, who are two amazing researchers who have taught me how to think and tell stories differently and are really moving the conversation and the practice forward for so many other people across the country. I'm so grateful to do work with them. To two of my palliative care heroes, Jody Waldron and Wanda Reggie, whose wisdom lives rent-free in my brain and I call on all the time. To my colleagues at the Palliative Care Training Center, especially Amy Trowbridge, Kristen Childress, Helene Starks, and Carolyn Hurd, who have taught me just more than I could even conceptualize about what it means to do this work and share this work. A big thank you to Meg Mullen, who is the person who actually started this program that I work in now. She's the reason that I have this job. She started our program as a pilot project when she was a fellow, and she didn't get to continue working in and developing this program, which I know is a sense of loss for her and has been such a gift for me. So I honor that this work started with her. She did all of the legwork to help grow what this is today. And I want to thank Kelly Campbell and Joe Hufford, my two colleagues in this program, who I love so dearly. I know that Joe will probably never listen to this, so he doesn't have to listen to me get emotional talking about how dearly I love him and how much I've learned from him. There's no person better in the world of being able to show up and build rapport with a person who has years of trauma and hurt relationships showing up in their care. I want to thank all of the people, especially women across the world and time, who have been caring for people at the end of life for millennia, who are often uncredited mothers of this work and the systems of knowledge and practice in which we currently work. And I especially want to give gratitude to my patients who have been my greatest teachers. Who, through much of their own energy, they give so much of their energy to their own physical, psychological, and social survival that they don't have the resources or access to represent their own stories and perspectives in these privileged spaces. I hope that this time can honor their wisdom and uncompensated labor of teaching us all how to care and advocate for them. I'm so grateful for the people that I've met in this work. And I want to say that includes all of you. I have the privilege of working at this unique intersection of suffering, caring for people who experience homelessness who are also living with serious illness. While that's afforded me a unique perspective, this really is all of our work. If you provide healthcare, you're going to serve people without housing. And my colleagues who work across the housing service continuum are no strangers to serious illness and death. I've already spent a lot of time talking, but I want this time to be a dialogue. So, one of the first things I'm going to ask you to do is to take a moment and find a place to write, whether it's your phone, a piece of paper. And I'm going to ask you to reflect on a person that you have cared for who is experiencing homelessness and a serious illness or advanced chronic illness. I want you to call them to mind and take a moment to write their first name and maybe a sentence or two about the situation they were in that you shared with them when you met them. Maybe with whatever you've written or whatever you're still writing, I invite you to take a moment to think for yourself what was challenging for you in supporting and caring for this person. And more than just challenging, how did it feel to be caring for them through that challenge? Maybe also reflect briefly on what change did the situation call you to make? What adaptations, what creativity? And finally, I invite you to write maybe even just a few words about something that you can say that you respect, admire, or love about this person. I hope that you can hold these patient teachers in your mind and your heart today as we talk about this practice, as we talk about your practice, as it frames an understanding of things that I might say or questions that you might have, or ways that you might take this work forward. So I promised I would actually talk about my program and the work that I do. So I'll do that now. So the Homeless Palliative Care team at Harborview Medical Center, we are an outreach team. I would say we're not a street medicine team. We don't have the capacity, given our small part-time team, to be out in the world searching for people who have a serious illness and need our care. But we do receive referrals across the entire community for people who meet exactly that criteria, have a serious illness diagnosis, and are experiencing homelessness. And really, the outreach portion is we have the capacity to go and meet people wherever they are, especially for people who have a really hard time connecting in to traditional brick and mortar services. So we are able to go out into the community. We're able to leave the walls of our clinics and hospitals. We are able to traverse the system as well. I will see patients at Swedish. I will see patients in a co-visit over at Fred Hutch, where I am right now. We have the opportunity to be mobile and meet and follow and help our patients navigate through the systems as they need to. Like I said, we're an entirely part-time team. There is a nurse practitioner, Kelly Campbell, our nurse, Joe Hufford, and myself. And our patients, when I talk about homelessness, what we use is the HRSA definition of homelessness, which is different than HUD, Housing Urban Development's definition of homelessness. One of the biggest differences is that includes people who are living in permanent supportive housing. So a lot of DESC and Plymouth buildings, we are able to see those folks according to the contracts that we follow. It's also important for me to note when we talk about the patients that we see, they represent the same disparities in racial and ethnic makeup that the rest of our community does in terms of homelessness. So people without housing are more likely to be people of color, people who are queer, people who are veterans, people who are transgender. And that shows up in our patient population as well. So the people that we see really do reflect the people who are experiencing homelessness in our communities. When I talk about our work, it's interesting to be talking to a group of, I think, people who would come to a palliative care ground rounds, because many people here do serious illness and end-of-life care. We do a lot of the same work. The differences really, one, include us being able to be mobile. So we will go to shelters, we go to supportive housing, we will go to encampments, we'll see people in vehicles if we can find them. If we can't find them in the community, we will put them on our watch list and we get an ADT alert when they show up in Epic if they go to an area hospital. And we will go, like I said, to Swedish. We will go to Virginia Mason. We will go see our patients where they are, which means we show up as ad hoc team members to a lot of your care teams, sometimes whether people like it or not. Sometimes I think of us like the family member at bedside who happens to have is a medical professional and seems a little annoying, wants you to be really, really clear that they know things, they care about this person, they will advocate. But we will show up wherever people are. We also accompany a lot of our patients, truly picking them up wherever that might be and bringing them to clinic if that's what it takes to get them in and through care. We coordinate a lot of the care, we make appointments, we reschedule appointments very often. But we will also be the eyes and the ears, and sometimes a support for the voice of our patients in a clinic visit or at the hospital. Many of our patients do have people in their lives, but they don't always have someone that's going to show up like my husband would, I always say, if I got sick, for an appointment with an oncologist or at bedside at the hospital to help me understand what's going on, to help me communicate my values and advocate for my needs. So we get to be those stand-in surrogates in a lot of different spaces. And I think about the people like one of our patients, Mama, who just wouldn't have gotten surgery to a resection of her colon to remove cancer. She's been cancer-free. She was one of our very first patients when I joined this team nearly 10 years ago. She's been cancer-free that whole time because of a surgery that she got that I think, frankly, only happened because we were able to help navigate a complicated conversation about the cultural meaning of being ready to die that was not suicidality. Or our patient with schizophrenia, who is a very tall, very loud, very black man, who, when he got upset, could be loud and assertive, but could also step out of the room and help him navigate through care and help other clinicians understand his perspective and how to support him even in times where he was dysregulated to be able to get to a place where I now see him walking around downtown. Sometimes he doesn't even recognize me, but I get to know that he's cancer free because of some of that work that we got to do. We also focus a lot on education. That means talking about our program and talking about our work in various different ways. This is one space to do that. I welcome many other spaces in which to do that. We are the only mobile homeless outreach palliative care team in the United States. There is a program called Peach in Toronto that does very similar work. And there are many other cities that are doing many other creative things, though. There are cities that have hospice houses for unhoused adults with advanced care planning programs embedded in shelters or embedded in outreach clinics. And there's palliative care initiatives as part of like other downtown clinic programs in places like Portland and San Francisco. There are lots of people doing this work. We just have the privilege of doing this particular model of work. I'm going to stop there and see if anyone has questions about the structure of our program before I talk a little bit more about homelessness and some of the work that we do.
Michael, you have a question in the chat. Oh, and a hand up too. Sorry. Whichever one
Yeah,
you would like to do first.
you mind facilitating?
Yeah,
Great.
happy to. So in the chat, question for when your team visits palliative care folks in other hospitals, when the person is also seeing pal care inpatient at adjacent centers to Harborview, such as Swedish or VM, how does communication flow from your team to ours? Where does documentation happen if it happens?
Yep, that's great. Thank you for that question. Yeah, one of the things that we think about, we train in the Palliative Care Training Center is for people introducing palliative care, we're not here to replace your care team. We're here to add to your care team. We just get to do that on like a much broader scale. And so we actually get a chance to work with palliative care services wherever our patient's at. So if we know our patient is engaged with inpatient palliative care services, usually the first people that we're talking to are the bedside nurses. And then usually it's the resident or attending to sort of link in and sort of say like, hey, we know this person really well, or we're trying to get to know this person. Help us understand what's going on, and we can help tell you what we know about this person and maybe the world around them outside and what we think is going to be a transition of care. If we know that palliative care services are involved in that point, we're really happy to work with palliative care services. Laura knows what was in the office yesterday working with the inpatient palliative care team at Harborview. So we're always happy to partner in care, and that includes outpatient palliative care services too. We've had a number of patients with Fred Hutch, Swedish, Virginia Mason, Harborview, where we actually share care. Our goal, if people can access brick and mortar services, that's great. They maybe don't need a mobile outreach team. Some people really need, they're never going to access or have significant difficulties accessing a clinic service. So we're the right team to go to. There are some people that sort of fall in between, or maybe there's a transition, and sometimes our services can overlap. It's always a question of how do we partner and how do we add, and especially this mobile component if we have the opportunity to access and see people's living conditions as well and help translate some of the information of that lived experience back to other teams, we're happy to do so.
Thank you, Michael. I think I saw Shannon's hand next, and then I'll pivot to the last chat question.
Hi, Michael. Good to see you. My question for you was, what initiates the process of somebody connecting with you and your team, especially given how fragmented the system is and how easy it is for people to fall through the cracks?
Yeah, that's a great question. I say that we accept referrals from anyone, anywhere in the community. So sometimes that is really truly like concerned community members who Google us and find us and call us and leave a message about someone that they like pass on the street on the way to work. Oftentimes that comes from healthcare professionals, but also other human services and housing professionals. So the people that we get to know, especially in supportive housing or shelters, they get to know our work and they identify people that they're worried about. And I always say that if we have this basic criteria of unhoused, which includes supportive housing, most people can sort of picture kind of what that is, and a serious illness. Then I say, if you're worried about that person, they meet those two basic criteria, give us a call. Different than other services, a thing that I actually get frustrated with truly is an epic referral that I just find a couple of days or a few days later, maybe a patient's already discharged from the hospital. I've got no context and I can't get a hold of someone to talk to the person. I like to think of ourselves a little bit more like an inpatient palliative care team, or how I imagine you operate, which is the like, if you're concerned about someone, call us. Then we can have a conversation about both what the perceived need is, what the opportunities are, and then we can offer consultation, which I say can result in a number of things. It can result in recommendations that we make, especially if it's a person that's outside of, we only see folks in kind of Seattle, not all of King County. We're just too small to be traveling to Burien or Bellevue. But if they are someone like across King County, we're still happy to like offer perspective and insight and information or resources if we have it. So we're happy to be a consult service. We're happy to give ideas about things that you can be doing to support patients. Sometimes we'll agree to see patients, like, let's see them together and see if we can add something to the conversation. And maybe then we will decide if there's an ongoing role for our team. And I always say that some of that is really based on the capacity that we have of our census and how complex our census is at any given time. But none of you need to know that back end stuff. That's for us to know. It's for anyone on this call or anyone else in our community to say, I know this person's unhoused and they've got a serious illness and I'm worried about them. Let's start with the phone call. And it gets to be a conversation from there about when and what and how much and how often truly we can do. I hope that answers.
Thank you so much.
Michael, there's one more question in the chat, but just to, oh, two more questions, but just to call out the Swedish Cherry Hill Palliative Care team is just saying how wonderful it was to partner with your team.
We
The
appreciate them frequently.
the two questions are different, but I'll list them together. What is the phone number to call with referrals? And then second question is, who pays for the service? How are you funded?
Great question. One, I can put the number in the chat. You can also Google Homeless Palliative Care Seattle, where the first thing that's going to come up. We have a website. It's got all of our information, and technically there is a consult request. It says right now referral request, I think, button on our website. So you're welcome to access that. I can make sure that gets set down later too. Our phone number is on that page, 744-5060. If people have insurance, we do bill their insurance, but our system, we work really hard. If people don't have insurance, they do not need to have insurance or any form of funding in order to receive our care. We work pretty hard to make sure that like any coding that we're doing, that we're not billing, that no one that receives our care ever receives a bill for our care. We work with a lot of folks with alien emergency Medicaid. So folks who are maybe don't have documentation that allows them access to basic healthcare services, only specialty care services like cancer treatment or dialysis.
Michael, that was my question. And I think part of it was, if you can visit people trans-system, are you getting funding from outside UW Medicine? So UW Medicine is footing the bill for you to be everywhere.
Most of our funding comes from the King County Healthcare for the Homeless Network. So part of King County Public Health that funds a variety of different programs, including like nurses in shelters and supportive housing like centers across town. So yeah, we do have a wide range of places that we serve and support. That's most of our funding. Obviously, that contract, if anyone knows grants and contracts, especially for federal, county, state stuff, it doesn't cover everything. So Harborview does pick up the cost a lot for us. We really are the big cost of our program. We've been honored to receive some small grants that allow us to provide for some small patient engagement, patient care things as people need them. Food, gift certificates, clothing, blankets.
How many people do you think need to be on your team to be right-sized for the need? Like you guys are not a full-time team with 3 people. What do you think would be the right size of your team to actually meet all the needs that you are perceiving, even if they don't always come to you?
I don't know that I've said this on a call, especially a recorded like session at all before. I'm really glad that we have the chance to do this work. And I think dedicating some amount of outreach time to reach people who cannot reach into us is an important and meaningful adaptation for any palliative care program, any outpatient palliative care program. We actually are housed in the downtown programs of Harborview Medical Center, not the palliative care department. So we're still sort of separate in that way, although we have these close relationships. When I think about other cities, other communities that want to develop a program like ours, I'm not sure that that's what I would recommend. I would recommend probably figuring out what are the adaptations that another outpatient palliative care service can do to sort of say, like, how do we carve out some time for some people to be able to be mobile? That creating a whole mobile team, it's an investment in resources, and I don't know that it's often like realistic for a lot of other like programs. So, but thinking about where we create at least some space to be doing similar work, I think is important. And truly, it's where we partner with people who are already engaged with our patients in the community. There are lots of people in the world who are doing outreach work. We just don't think of them as healthcare professionals. We don't engage them as healthcare professionals. We don't engage them as advocates and leaders in patient care. And I'll talk about that a little bit too. With the time that I have, and there are so many other things I want to say, I'm glad that I get to stick around and talk to the Fred Hutch team a bit more after this. I have a lot to say about homelessness and questions that I wanted to ask you, but the things that I want to just frame before we talk about adaptations in practice is to first remember that when we're talking about homelessness and people who are experiencing homelessness, that there's a lot of bias, socially contrived bias. When we imagine flipping through the news and seeing a story about homelessness on TV, the images that we're likely to see influence the story, the narratives that we tell about homelessness, and the implicit bias that we have. And I think it's something that causes a sense of discomfort in us, and that's hard not to bring to the bedside. To hear from our colleagues, we might not believe that that's really deep in ourselves, but we can see it show up in healthcare. And if it's showing up in healthcare, it must live, at least in some way and part inside of us. That implicit bias still lives inside of me, and I have to recognize that too. And we talk about homelessness, it's often, I think, a euphemism. We're really talking about really complex psychosocial and structural barriers to housing. We're talking about people who have a lot of other complex psychosocial needs. And one of the questions that I was hoping maybe there'd be time to put this in the chat, but I just want you to imagine a list in your head of the social drivers or determinants of health. This is, I think, common language to most of us now. And if you think of any of those social drivers of health, they're also social drivers of homelessness. That homelessness, to say it here, even if we all agree and feel like this is true, maybe we don't all, that this is as a social driver of health, that means it is a societal problem that needs to be addressed by social policy, not an individual moral failing of individuals. When I think about homelessness in this country, I've come to regard it as an experience of people being internally displaced political refugees. They're victims of policy decisions that disregard human life and say that right to housing, and as we know, basic right to health, is not something that we have codified into our policies. That this is a capitalist structure that says you need to earn your keep and earn your right to have housing. And maybe we'll give you some, but we'll also make sure there's restrictions around it and use an economic framework to decide who and how many people receive it. When I think about this in the context of a total pain model, we need to remember that the total pain 4 buckets, which I really love, needs to include structural and institutional and generational trauma, oppressive trauma that people experience that cause pain and suffering. It's not just social, it is societal. And to appreciate that when we're talking about this intersection of suffering, the other question I would have you think about is to list the types of loss that people experience when facing serious illness and approaching end of life. For example, the loss of identity, the loss of possessions, role, faith, health, function. When we think about all those forms of loss, when I think about my patients, those are things that they have lost and been dispossessed of, sometimes many times over, for many, many years. And it doesn't mean that the new experiences of loss that come with serious illness aren't impactful, they're just compounding. And often what it does is it accelerates exponentially sometimes the experience of that loss. One of the things that I think about for myself as a resourced individual is that if I had a serious illness, I have a pretty clear sense of what my safety nets are to ensure that I'd have a place to live and where I would receive care. And I have a lot of choice in shifting my resources to shift my experience and how I get to navigate the system. And without those resources, I am pushed through the system and I have less choice. I have less autonomy in what happens to me. And it's part of the form of violence that our patients experience all the time. There's a quote from this paper, Dangerous Places, Exposures to Violence and Its Mental Health Consequences for the Homeless, that homelessness is more than the absence of physical shelter. It is a stressful, dehumanizing, dangerous circumstance in which individuals are at high risk of being witness to or victims of a wide range of violent events. The violence of removal, the violence of hate crimes, the people I know and came to care about who were murdered on the street. This is a stress-filled, dehumanizing experience. This is a different form of suffering, and it's suffering that I think is important for us to be able to sit with and look at and appreciate if we're going to be trauma-informed in our work. In the last few minutes that I have here, that's what I want to talk about, is just a few things that help me frame a little bit more how I approach this work. The first is building off of this idea of trauma-informed care. We talk a lot in our training center, maybe the University of Washington, about the values triad. If anyone's not familiar with this, it's the idea that we're often listening for people's values when they have to make hard trade-off decisions about what they care about most. Are they more looking towards a trade-off of comfort or longevity or maybe independence, somewhere in between, especially in those times where they can't necessarily have all three or have even two? And helping shape an understanding of what drives people's motivations to clarify the choices they make is incredibly important. When I think about my patients, the thing that I add to that and above all three of those categories is safety. My patients seek often safety before they're able to explore their healthcare choices around other values. A patient that self-discharges from a hospital, a patient that says, one of my really beloved patients who, like, I want to go to dialysis, I want to live, but can't make it to dialysis is in too much pain, too much anxiety, has a hard time being able to be in the space without using substances and having conflict with the staff, and will choose to remain home and say, like, the ride has arrived that you said you wanted, and you're locked in your room and you won't come out, knowing that it's going to lead to a thing that you also don't want, which is to go to the hospital, a place you hate being, where you don't want to be intubated, but you do want to live. Often we see this ambivalence and we get confused about, like, what is the choice? What is the underlying value? How is this person making decisions? And because it's not within that value set, sometimes it's really about seeking safety first, trying to regulate a dysregulated nervous system after many, many years of lacking trust and needing to be on high alert. That causes us to either shut down or feel like we're in fight or flight mode. It's one of the reasons that I talk a lot at the start about accessing our space of love and being able to ground that for ourselves, because it is only when we're able to show up in authentic relationship and ground ourselves and self-regulate that we can sometimes hear that story and detach ourselves from the outcomes of care and focus more on what our patients need, which is the relationship of care. When I think about that total pain model, I remember how much is lost for many of our folks in social connection. And that might be in their personal life, that might be in their family system, but that's also happened relationally in healthcare for a really long time. And one of the things that I can do when I appreciate the analogy I use is I often can't keep this car that's flying down a bumpy road towards a cliff. I often can't right the direction of that car. I can't keep us from going off the cliff. I can ground myself, take a deep breath. Instead of turning away or running away or trying to push the car, I can sit in the passenger seat and I can be present for that journey. And I can focus on the relationship. And that intervention of the relationship in and of itself is an intervention of healing that reduces suffering or can reduce suffering. My husband had a patient once, he's a social worker at the VA in addiction treatment, and he had a patient who was diagnosed with cancer. And he said, we went from talking about substance use goals to talking about end of life. And I feel like I don't know what I'm doing with him right now. I feel like the only thing I'm going to do is have a relationship with him until he dies. And I said, yes, that's what you're going to do. That might be all that you do. And that might be everything. That is the true gift for me of this work, is building these relationships. And I think for a lot of our patients, that is the gift that we offer them. Another thing I wanted to touch on, I'll try to touch on two more things here before I close. One, this idea of the surprise question. And if anyone knows this, this is the, would you be surprised if this person died in the next year? When we think about people who are unhoused, this is a group of folks with the many systemic barriers to accessing care. They get sicker, quicker, and die younger. They get diagnosed with serious illness at a later stage. They have more comorbid conditions. They experience more complications. They have more hospitalizations. The life expectancy for someone who is living chronically unhoused in the United States is 48 to 52 years old, which is the life expectancy of someone living in the United States, the average person in the United States in 1920. 100 years of medical advances and the same life expectancy if you don't have access to. We spend a lot of our time, a lot of our patients who have a hard time accessing care end up in these spaces of episodic care when they get really sick, trying to keep themselves safe and protected the best that they can. And often we attend to a crisis without sometimes stepping back and saying the surprise question needs to be a lot broader for folks who we know are such high risk for a serious illness complication, sudden death, trauma overdose, the conversations we should be having about values and exploring, even when that is a brief encounter in the hospital, we should be having these conversations more frequently. This should be primary care practice for any person, primary palliative care practice for any person who is experiencing homelessness, especially chronic homelessness, especially folks who use substances as well. And the last thing I will say with my limited time here today, and I'm still going to try to hold appreciation for, I'm still glad that I took up as much time as I did sharing from my heart earlier. I'm happy to share more about this work and these practice frameworks. But I mentioned earlier that there are a group of people that we forget about when we think about serious illness care. And those are the community case managers. Those are the outreach workers. Those are the healthcare professionals that are embedded in the community who work with people who are experiencing homelessness. They're the people who have relationship and they have context for understanding the world and the limitations, the barriers and facilitators in which that person might be living. In many ways, I think of these people as the pseudo surrogates for our patients. There have been so many times we've had a patient in the hospital, they don't have a DPOA. We get a hold of a family member that hasn't talked to them in 20 years, has a strained relationship. We're asking that person, do you want to be involved in their care? What's most important to them? That's really complicated. The people that we forget to reach out to are the people who already know and care about our patients, who maybe don't have the language and the framework to understand how to communicate. They sometimes don't feel like they've got the positional power to know who to reach out to know that they have a role in a patient's care, but who are an invaluable source of wisdom and knowledge to support us as clinicians, to support that patient and understanding how they live their life, even if they've never made direct comments about what their values or medical limits might be, and supporting family members who might not know as well. It really, I think, is incumbent upon us to say, who else do you have in your life? Who else are you working with? Documenting that so that we have people that we can bring into those conversations, because they don't know how to reach out to us. They don't know how to frame it. They might be scared to do so. They also don't necessarily have the training and support to sit with the grief and bereavement that comes with that work, and they need that support from us as well. There are so many other things that I want to talk about. A harm reduction framework for how we think about treating patients who have a substance use disorder and have pain. There are things I want to say about treating our patients as experts. And there are things I want to say about honoring the legacy, the true legacy that our patients do have, that's not connected just to belongings or having a particular person to hand those things down to. But I'm going to close just with a poem from one of my patients to highlight a sense of legacy and some of this experience. It's a poem 2023 called From Shade to Shadows. It says, these days I've come to hate the sun. The heat can be unbearable. From shade to shadows now I run. To have no shelter is not much fun when living in your vehicle. These days I've come to hate the sun. Attention's glare is what I shun. My life's become so flammable. From shade to shadows now I run. So fast is life that it will stun, gone like a melting icicle. These days I've come to hate the sun. Our world out of control, it's spun. The change is unbelievable. From shade to shadows now I run. The need to hide has just begun. It hurts to write this chronicle. These days I've come to hate the sun. From shade to shadows now I run. Thank you for letting me speak and share. And thank you for your questions. And I will remain here for more. And I'm very happy to talk in great detail for many more hours with any of you who would like to.
Very clear.